So guys, the next topic we are starting with is the cerebrum. And in the cerebrum, first let us start with the types of the sulci and gyri. We'll see what type of sulcus we have, how we classify them. Then we will go on to the cortex, the cerebral cortex, where we will talk about the homunculus, the different areas in the cerebrum. We'll also talk about the cerebral histology also. And then followed by the most important topic, I would say, in the entire neuroanatomy, that is the white matter of the cerebrum. So let us first start with in the cerebrum, let's start with the types of the sulci. So we are starting with the types of sulci. Now, as you know, there are so many sulcus we have in the brain, all those sulcus like the central sulcus and calcarine sulcus. So how we classify those sulcus? So we broadly classify these sulcus into the following categories. Like, there is one type which is called as a limiting sulcus. That is called as a limiting sulcus. Now, what is a limiting sulcus? As the name suggests, the sulcus which is limiting the two different areas, but the important thing is that limitation is at the floor of the sulcus, or very much in the depth of the sulcus. Let me explain that diagrammatically. Let us say if this is one gyrus here, and there's another gyrus here with a different function. So as you can see, this, if you look at the depth of the sulcus, there is a point where these two areas are meeting. Now let's say if there is a sensory area and motor area, so they must be meeting at some point. That meeting point over there is found in the depth of the sulcus, and those type of sulcus are called as what? Limiting sulcus. So the sulcus, these are the sulcus which separates different areas at the floor of the sulcus. The floor is a keyword here. They're separating, but at the floor of the sulcus. The example of the limiting sulcus will be, the best example will be the central sulcus. And another example is the calcarine sulcus. I'll tell you more about this sulcus when we'll look these sulcus on the areas of the brain. So the central sulcus, especially the central sulcus, we all know, separating the sensory and the motor cortex. And this separation of the sensory and motor cortex is very much at the depth of the sulcus here. Please also remember that central sulcus is also called as a Rolandic sulcus. It is also called as a Rolandic sulcus. The second in the category is called as the operculated sulcus. That is the operculated sulcus. What are operculated sulcus? Now, once again, let me use the diagram to explain that. Now, let us say this is some area with whatever function. And look at this different color here, which is representing the area with a separate function. So now you're looking at the two different type of areas again, but this time the zone of transition or the meeting point is not in the depth. It is very much at the margin, or you can say at the operculum. Operculum means what? Lips. So when you open this lip here, when you open the sulcus, you will see that there is an entirely different area which is present inside. So basically, operculated sulcus are just like limiting sulcus only, but the difference is their transition is not in the floor. The transition is at the top, is at the lip. So I would say they are just like limiting sulcus, but transition is at lip. The transition there was at the floor. That was a key thing here. And here the transition is taking place at the lip. That's the area from where the function will change. The example for the operculated sulcus will be the lunate sulcus. As I said, we'll discuss all these sulcus in a while. That is a lunate sulcus. Lunate sulcus is the one which separates striate and peristriate area. It separates striate and peristriate area. That is the second type of sulcus, that is operculated sulcus. Now, quickly moving on to the third type. The third type of sulcus is called as the axial sulcus. That is called as the axial sulcus. Now, what is axial sulcus, guys? Axial sulcus are those sulcus which separates the different areas, but that is based on how they are winding around the sulcus. What I'm trying to say here is, let us say if there is one sulcus, and around that sulcus, if you see the different type of areas are developing, and they are using this sulcus as an axis. The best example, like visual cortex. If you look in the visual cortex, we have a calcarine sulcus, and around the calcarine sulcus, we got area number 17, then we got area number 18, and then we have area number 19, which is further around it. So that type of sulcus is called as what? Axial sulcus. The word axis is important here. So this is a gyrus here, that is the sulcus, again it's a gyrus. So look at this, this is what I'm talking about. So you can see all these different type of areas developing around the sulcus. So basically sulcus around which different areas develops. Around which the different areas develops. And the example for the axial sulcus is the posterior part of calcarine sulcus. The posterior part of calcarine sulcus is an example here. So calcarine sulcus, yes, but what part of the calcarine sulcus? The posterior part. And then lastly, we have the fourth type, and that is called as the complete sulcus. That is the complete sulcus. Now, what is a complete sulcus, guys? Again, let me try to explain that with the diagram here. If this is a sulcus, the sulcus which is going so deep inside that it is indenting the wall of the ventricles. So here is the wall of the ventricle. Let's say it's a ventricle here. Obviously, the lateral ventricle. Maybe any horn of lateral ventricle. So if the sulcus goes deep inside, and it goes so much deep inside that it ends up by putting an impression or making an impression on the wall of ventricle, that is called as a complete sulcus. So these are the sulcus which are deep enough to indent the walls of ventricle. They're deep enough to indent the walls of the ventricle. The example for this type would be, one is the anterior part of calcarine sulcus. One is the anterior part of calcarine sulcus. We just saw posterior part of calcarine sulcus was the axial. So here we have an example of anterior part of calcarine sulcus. And another example is the collateral sulcus. Anterior part of calcarine sulcus and the collateral sulcus. Let me just use a different color for the collateral sulcus. Now, I mean, if I have to show you that what exactly they are indenting, we are still supposed to discuss this ventricle in a while, but look at this. If this is a lateral ventricle, let's say, and we know that lateral ventricle is having this anterior horn, we got inferior horn, and this is the posterior horn. So this calcarine sulcus, if I go with the color code, anterior part of calcarine sulcus will indent the posterior horn, and the collateral sulcus will indent the inferior horn of the lateral ventricle. And those elevation which are formed here because of these respective sulcus, go with the color here. Anterior part of calcarine sulcus forms an elevation on the posterior horn, and that elevation is called as calcar avis. That is the calcar avis. Whereas the elevation which is formed on the inferior horn of the posterior of this lateral ventricle, which is because of collateral sulcus, is called as collateral eminence. That is collateral eminence. Now, where exactly this collateral eminence and calcar avis are, we will discuss that. But just to again remind you that is why we call them the complete sulcus, because the calcarine sulcus, the anterior part of calcarine sulcus is indenting the posterior horn, and the collateral sulcus is indenting the inferior horn of the lateral ventricle, called as the collateral eminence and the calcar avis. So one important thing to note from here is that the sulcus which is counted in all three, which is limiting also, which is axial as well, and now you can see this complete sulcus as well, is a calcarine sulcus. Now that again can be a question asked, that which sulcus is counted in all the three categories. And the question remains is that if we just cover like 4 or 5 examples in this in the classification of the sulcus, what about the other sulcus that we got? There's so many sulcus we have in the cerebral hemisphere. For the majority of the sulcus or the remaining sulcus in the brain, they don't fit into any of the category, and we call them incomplete sulcus. So the other examples, apart from what we discussed here, the most of them will come into a category which is a kind of 5th category, you can say, and that is called as what? Incomplete sulcus. The sulcus are called as incomplete. So that is about the classification of the sulci. So guys, having talked about the types of sulci, now let's talk about the important areas in the brain. So first we'll begin with the superior lateral surface of the brain. We'll see what are the important gyrus and sulcus we have and the important areas. And then we will look at the medial surface of the brain, and we'll also look at the areas in that region. So I'm going to start with the superior lateral surface of the brain. So when you see the superior lateral surface of the brain, this is how it's going to look like. This is the Sylvian sulcus. And let's say this is a central sulcus, right? The two sulcus which we can easily identify, the Sylvian sulcus and the lateral sulcus. Sylvian sulcus and lateral sulcus. Now this Sylvian sulcus is actually only the posterior limb of lateral sulcus. When the lateral sulcus emerges on the superior lateral surface of the brain, it is having 3 extension. One is the upward extension like this, and then we have anterior extension also. And the one that you're looking at going backward, it is the longest posterior extension of the lateral sulcus. This here is pre-central gyrus. This is post-central gyrus. I'm sure you all know that, pre and post-central gyrus. Let me mark this, only this one, the central sulcus. This is called as central sulcus, also called as a Rolandic sulcus. Central or Rolandic sulcus. Now what you see, all these 3 limbs of the lateral sulcus, they are all present in the inferior frontal gyrus. So these are 3 frontal gyrus we are looking at. The superior, middle and inferior frontal gyrus. Just make sure all these limbs are extending into the inferior frontal gyrus. We got 3 gyrus in the temporal lobe also. This is superior temporal, middle temporal and inferior temporal gyrus. On the top of these sulcus, we have a supramarginal and angular gyrus as well. We'll see all these areas. I'm just drawing it first. And please also draw a line here dividing the parietal lobe. This is parietal lobe. It is dividing the parietal lobe into superior parietal lobule and inferior parietal lobule. And this here is a calcarine sulcus. This here is a calcarine sulcus. So I'm going to draw it twice actually. Let me just mark the important areas here first, and then we will see what is present where. Now this here is the pre-central gyrus. This is a pre-central gyrus, and this is a post-central gyrus. This is superior frontal gyrus. We got a middle frontal gyrus, and this is inferior frontal gyrus. I'm just writing them in short. So this is superior frontal, middle frontal, inferior frontal gyrus. What you see that in the inferior frontal gyrus, please notice these 3 areas here. This one here, which is between the posterior limb and ascending limb of the lateral sulcus. Then we have the one between the ascending limb and the anterior limb. And the one that you see which is present inferiorly toward the orbital surface of the cerebrum. And that is how they are named. If I give it A, B and C. Guys, A here, that's an important area called as pars opercularis. This is called as pars opercularis. Whereas if you look at this B, which is between the ascending limb and anterior limb, this is called as pars triangularis. This region is called as pars triangularis. And if you look at the area C, which is present below this anterior limb that is called as pars orbitalis. That is pars orbitalis. So we have these three important areas here: pars opercularis, triangularis, and orbitalis. Especially these two are very important because they will have Broca's area in them. So we'll talk about them in a minute. Then please also mark this important area which is present here. That is a superior temporal gyrus, middle temporal gyrus, and then we have inferior temporal gyrus. The three temporal gyrus: superior, middle, and inferior temporal gyrus. Then we said we have parietal lobe divided into this superior parietal lobule, and this is inferior parietal lobule. Larger gyrus is called as lobule. So we simply call them lobule. It's a gyrus only. So we have a superior parietal lobule and inferior parietal lobule. This is interparietal sulcus we are looking at. And this sulcus is the calcarine sulcus. That's an important one. The calcarine sulcus, which we just discussed, calcarine sulcus, which is it is a type of a complete sulcus, a limiting sulcus, an axial sulcus, that calcarine sulcus. Please also mark these two important areas here, that is this one and this one. Let me again give them some numbers or something to remember. So let me give them D and E. The D, area D, that is called as supra marginal gyrus. This is called as supramarginal gyrus. That is D, supramarginal gyrus, and E here is for the angular gyrus. Another important area, that is supramarginal and angular gyrus. You will find components of Wernicke's area are present here. So this is just the superior lateral surface we are looking at, and the important gyri and sulci. Now let's use the knowledge of all these, where these gyri and sulci are, and let's mark where the important areas are present, what their function is, and any injury to those areas will lead to what. So I'm again going to take the same diagram here, guys, but this time we'll be marking areas on it. So there we go, once again, the superior lateral surface. The central sulcus, precentral, postcentral gyrus. Now please note that the postcentral gyrus is the sensory area, that is area number 3, 1 and 2. Whereas a precentral gyrus, that is area number 4. If I may draw these extensions of the lateral sulcus which are present in the inferior frontal gyrus, that is superior and inferior parietal lobule, and once again the temporal lobe, and behind that we have this supramarginal and angular gyrus. So this time we'll be writing the numbers of these areas. This classification obviously is called as Brodmann's classification. And look at this area number 4, which is in front of the central sulcus. Now, in front of this area number 4, occupying the part of superior frontal, middle frontal, and some part of inferior frontal gyrus also. Look at this area which I'm highlighting here. It is present in all the three frontal gyrus, the most posterior part of all the three frontal gyrus. This is area number 6. We call it precentral gyrus. I'll write about that also in a minute. That is area number 6. Then in front of the 6, especially in the middle frontal gyrus, that is area number 8. Let me highlight that also. That is area number 8. Superior parietal lobule is area number 5 and 7. You can see it's a parietal lobe. We said parietal lobe is divided by the sulcus. The sulcus is interparietal sulcus, and we have a superior parietal lobule having 5 and 7. Coming to this very, very important area here in the inferior frontal gyrus, that is area number 44 behind and 45 in front. 44 behind and 45 in front. This is 44. And then in front we got this 45. Remember these areas, the pars opercularis and pars triangularis. It's very, very important area, 44 and 45. Then in the superior temporal gyrus, we will have auditory cortex, and auditory cortex is area number 41 and 42. Just write these numbers with me. I'll be writing all these areas for you separately as well. That is 41 and 42 in the superior temporal gyrus, the auditory cortex. Surrounding this 41 and 42 is area number 22, which also is a component of Wernicke's area number 22. And then guys, this is area number 39 and 40. As you can see, you already know the name here. 39 is in the angular gyrus and 40 is in the supramarginal gyrus. 39 and 40. So some important areas. There are so many areas in the Brodmann's classification. You don't have to remember everything. So at least remember the important areas. And these are the ones which you can appreciate on the superior lateral surface. So let's do one thing. Let us write down these areas separately one by one and see what exactly their function is and what the injury may lead to. So there we go. Let us start with these very basic areas that we started with. That is area number 3, 1 and 2. And guys, see, I'll be writing the whole thing again because like 3-4 years back, nobody used to ask many questions from these areas of the brain. But since all these image-based questions are in trend now, so nowadays so they will just give you the picture of the cerebrum and just they'll put the arrow wherever they want. And they might ask you that what is the area, what is the blood supply of that area, injury to that area will lead to what are the effects of the involvement of that areas. So it's very important to know the number of the area, important areas at least, what is their function and their blood supply also, which we will discuss eventually. So 3, 1 and 2. What is the location of 3, 1 and 2? This is present in the post-central gyrus. It is present in the post-central gyrus, isn't it? And this area number 3, 1 and 2 present in post-central gyrus, the function is this is actually the primary sensory area or primary sensory cortex. This is the primary sensory area or the primary sensory cortex. Primary sensory area or primary sensory cortex. Any injury to this area, let us say this sign, let's say it's for the injury here. Any injury to this area will lead to the contralateral sensory loss. Contralateral, isn't it? Most of the tracts were decussating to the opposite side to reach the thalamus, and then thalamus will give the thalamic radiations reaching this region here. So let's say if the injury is on the let's take one example. If the injury is on the right cerebral hemisphere, so there will be loss of the touch and pressure sensation of the left side because the tracts were decussating in the brainstem or in the spinal cord to ultimately reach the cerebrum. Then we have this area number 5 and 7. I want you guys to think about it. Where is area number 5 and 7? Where you draw it? You draw it in the superior parietal lobule. You drew it in this superior parietal lobule. What this area is, this area number 5 and 7, which is in the superior parietal lobule, this is also called as sensory association area. This is also referred as sensory association area. For most of the areas we have there an association areas also. This is sensory association area. The association areas are for the previous experiences and past memory. That's what the association area will do. I mean, I can see an object coming towards me from a visual area. But what exactly that object is, what it can do to me, anything about that, the knowledge about that object is stored in my previous experiences, or you can say in my association areas. So association, whenever you say visual association, auditory association, or simply sensory association, so they are related to the previous experiences and past memory, which will help you recognize that particular thing based on whatever sensory stimulus you are using that time, visual or auditory, or maybe by touching it. So if there is any injury to this sensory association area, if there is any injury to the sensory association area, that will lead to the tactile agnosia. That will lead to the tactile agnosia. The inability to perceive the roughness or the texture of an object, that will be there. So tactile agnosia will be there in case of the injury to this area number 5 and 7. Then coming in front of the central gyrus, then we have this area number 4. Very, very important. Area number 4 again. What is the location for area number 4, guys? That is present in the precentral gyrus. Area number 4 is in the precentral gyrus, and this is the primary motor area or primary motor cortex. This is the primary motor area or the primary motor cortex. And please note, this primary motor cortex is the one from where we have, it is a main site for the origin of the corticospinal tract. Pyramidal tract or corticospinal tract. So it is a site for the origin of, let me write, pyramidal tract. Obviously, any injury to this area, primary motor area, will lead to the contralateral hemiplegia. It will lead to the contralateral hemiplegia. Then we have area number 6, which is right in front of the 4. Now, if you look at what is the location of the 6, area number 6 is located in the superior frontal gyrus, middle frontal gyrus, as well as inferior frontal gyrus as well. So it is situated in all the 3 frontal gyrus, superior, middle, and inferior, the posterior part of the 3. The posterior part of the 3. This area number 6, please note, it is the premotor area. This area is called as premotor area. It is in front of the motor area. It is in front of the 4. So we call it premotor area. And this premotor area, it is a site for the origin of extrapyramidal tract. It is a site for the origin of extrapyramidal tract. That is a site for the origin of extrapyramidal tract. All those corticorubral and corticobulbar and corticopontine, you know, apart from the pyramidal tract, whatever descending tracts we have coming from the cortex, that is extrapyramidal tract, they will originate from this area number 6. Okay. And if there is injury to this area number 6, there will be the case of apraxia. Injury to area number 6 will be the case of apraxia. There will be difficulty in performing the skilled movement. So apraxia, difficulty in performing the skilled movement, will be the cause if there is area number 6 is affected. Moving on, guys, in front of the 6 we saw area number 8. Area number 8, which is situated in the middle frontal gyrus. Well, it is not only in the middle frontal gyrus. Many books will show you that this area is projecting into the superior frontal gyrus also, and you can see it on the medial surface of the cerebral hemisphere along with area number 9. But usually, mainly it is in the middle frontal gyrus, the area number 8. This area is called as the frontal eye field area. That area number 8 is the frontal eye field area. And this frontal eye field area, please note, it is for the scanning ocular movement, and it is independent of the visual stimulus. It is for the scanning movement of the eyeball, but independent of visual stimulus. Remember that. So the function of this area is for the scanning ocular movement, and it is independent of visual stimulus. There is no visual stimulus required for this frontal eye field area, that is independent of visual stimulus. This frontal eye field area, guys, if there is injury to this frontal eye field area, what will happen? There will be contralateral voluntary conjugate movement of the eye will be lost. So the conjugate movement of the eye will be lost in case of this frontal eye field area. Conjugate eye movement lost. Conjugate eye movement is lost. So, and the eye will be deviated toward the side of lesion. Remember that also. If let's say the right side frontal eye field area is affected, so there will be deviation of the eye toward the side of the lesion. Although the pursuit movement will be normal. So if you're doing this pursuit movement, you will find that is normal. But apart from, because that is controlled by the occipital lobe, right? But the scanning ocular movement, this voluntary scanning ocular movement will not be there, and you will see the deviation of the eye toward the side of the lesion only. That is the frontal eye field area. Now comes the most substantial and the most important, I would say, that is area number 44 and 45. And you can, the chances of asking the questions in your PGMA exam are most on this 44, 45. Situation of 44, 45, it is in the inferior frontal gyrus. It is in the inferior frontal gyrus. And I hope you remember, in the inferior frontal gyrus also, guys, where is 44? 44 is present in the pars opercularis. It is present in the pars opercularis, that was behind the ascending limb. That is pars opercularis. And 45, which is in front, it is present in pars triangularis. It is present in pars triangularis. Remember pars triangularis, between the ascending limb and the anterior limb. That is pars triangularis. 44 or 45, this area is important because this is the motor speech area or Broca's area. This is the motor speech area or the Broca's area. Have you noticed one thing? I mean, if you look at all these areas with a small number, like area number 3, 1, 2, 5, 7, area number 4, 6. Now all these basic areas are like for the primary type of sensation or primary type of motor activity. These areas were discovered earlier, so they were named earlier. So they have a like smaller number, 1, 2, 3, 4, 5, like that. And look at all these complicated or more advanced areas like Wernicke's and Broca's area and auditory association. You'll find their numbers quite high. Gustatory area, you know? So they have areas like beyond 25 and 28. There are certain areas 41, 42, like 44, 45. So higher numbers are usually given to the areas which were discovered later, and that's how this nomenclature went. The Brodmann's classification. So this motor speech area or Broca's area, guys, as we know, any injury to the motor speech area will lead to the motor aphasia. Broca's aphasia or the motor aphasia. Another important area that we marked in the diagram is 41 and 42. Where is 41 and 42? 41 and 42 is present in the superior temporal gyrus. It is present in the superior temporal gyrus. 41 and 42 in the superior temporal gyrus. Now why this is so important? Because this here is the primary auditory cortex. This is the primary auditory area or primary auditory cortex. We talked about in the auditory pathway also. Primary auditory cortex, also called as Hessel's cortex. This is also called as the Hessel's cortex. Primary auditory cortex or Hessel's cortex. This area number 41 and 42 is surrounded by the area number 22, which is also in the superior temporal gyrus. There only. Superior temporal gyrus. And area number 22, please note, it is the sensory, or I should say it is the auditory association area. This here is the auditory association area. Main auditory area is 41, 42, and it is encircled by this area number 22, that is auditory association area. And lastly, on the superior lateral surface, we got 39 and 40. Now, where is 39 and 40? 39 and 40 is present in, they are present in angular and supramarginal gyrus respectively. Angular and supramarginal gyrus respectively. 39 is an angular and 40 was in supramarginal gyrus. And please note, both these areas are the component of sensory speech area. Motor speech area was 44, 45. This 39, 40 is a sensory speech area, or you can say it is also the component of the Wernicke's area. It's the component of Wernicke's area. Now, I know what few of you might be thinking, that when you say Wernicke's area, especially in physiology, they say Wernicke's area is area number 22. Correct. area number 22, which is there, which is auditory association area, is connected by the arcuate fasciculus with 3940. So please remember, all three are the part of Wernicke's area. So it's not only 22. When you say Wernicke's area, you are actually considering 22, 39 as well as 40. 22, 39 as well as 40, and any injury to this 22, 39, 40, that is the Wernicke's area, will lead to the sensory aphasia. That can lead to the sensory aphasia. Now we just talked about the motor aphasia, and this is sensory aphasia. Motor aphasia plus sensory aphasia. As you know, when both these aphasia are seen together, motor aphasia and sensory aphasia together are global aphasia. That is the global aphasia. We have both the kind of aphasia simultaneously, that is global aphasia. And usually this global aphasia is because of the stroke of middle cerebral artery. It's the MCA stroke which leads to global aphasia. And see, it makes perfect sense. If you look at this superior lateral surface, you don't have to draw it, just understand this. And this here is the Sylvian cistern, right? That was a Sylvian cistern. What we have in Sylvian cistern, I hope you remember, that is the middle cerebral artery. Middle cerebral artery. So I'm saying that middle cerebral artery stroke will lead to the global aphasia. That makes sense. Why? Because it's the middle cerebral artery branches which is supplying the Broca's area, which is here, which is supplying auditory association area, which is here, and it is also supplying this 13 and 40, that is sensory speech area, which is here. So all these areas are supplied by the middle cerebral artery only. So the stroke or the involvement of the middle cerebral artery can lead to the global aphasia. It is the dominant artery supplying the superior lateral surface of the brain. So involvement of the MCA can lead to global aphasia. So that is about the superior lateral surface of the brain. So guys, now let's look at the medial surface of the cerebral hemisphere and identify the important areas on the medial surface. So for the medial surface, we'll take a sagittal section. Let us say this here is the sagittal section. So this time we are looking at the medial surface of the cerebrum. So this, let's say, is the corpus callosum. Obviously, when you take the sagittal section, you have to take it along the corpus callosum. And this here is the medial surface of the cerebral hemisphere. Take your time, just draw it with me. So this is the corpus callosum here, and that's the medial surface of the cerebral hemisphere. Now what you'll see a sulcus which is running parallel and above the corpus callosum, and you will see that sulcus turning upward like this. This important sulcus is called as cingulate sulcus. This is the cingulate sulcus. And between these two limbs here of the cingulate sulcus, you will see a slight projection of central sulcus. Central sulcus is present on the superior lateral surface of the brain, but you will see a small projection of that central sulcus on the medial surface. And why this projection is important? Because around this central sulcus, but within the limbs of cingulate sulcus, look at this area which I'm highlighting here. There's one very, very important area. This area which is actually present around the central sulcus, so we call it paracentral lobule. This is the paracentral lobule. The name goes like paracentral lobule. And why this paracentral lobule is so important? Because the paracentral lobule is the highest center for micturition and defecation. It is the highest center for micturition and defecation. Please note that. It is the highest center for micturition and defecation, the paracentral lobule. So the gyrus that you see, which is present below the this cingulate sulcus, that is called as cingulate gyrus only. This is the cingulate gyrus. That is cingulate gyrus. Now let us say this here is the calcarine sulcus. You saw the calcarine sulcus on the superolateral surface. You can better see it from the medial surface. That is the calcarine sulcus. Now what you see this, if you look at the continuation of the cingulate sulcus posteriorly via this connection that is called as isthmus. I'm just writing I for the isthmus. Via this isthmus, you will see it is connected to this parahippocampal gyrus here. This is the parahippocampal gyrus. This is parahippocampal gyrus that you see present in this part, and this anterior upturned part of the parahippocampal gyrus is nothing but the uncus. I hope you remember the uncus from the lateral relation of cavernous sinus. Remember we said the lateral relation of cavernous sinus apart from the cranial nerves, it was uncus which was outside the cavernous sinus. We also have this para-olfactory in the anterior part. You can see that is para-olfactory gyrus, and the one which is more inside, that is para-terminal gyrus. It is in relation to the lamina terminalis, so we call it para-terminal gyrus. Now my point here is, if you look at all these areas which are kind of encircling the corpus callosum, look at this areas I'm highlighting here, guys. This is para-terminal and para-olfactory gyrus. This is what? That is the cingulate gyrus here, right? That is cingulate gyrus. If you see posteriorly, that is isthmus. And then below here we have what? Parahippocampal gyrus, which is anteriorly going and forming the uncus. Whatever I've highlighted here, all these areas which are in the core of the cerebrum, that is the oldest part obviously of the cerebrum, that's why it is in the core, and they are all components of limbic system. Please note that they are all components of limbic system. I've already highlighted the cingulate gyrus and isthmus. So this parahippocampal gyrus, uncus, para-terminal gyrus, para-olfactory gyrus, they are all components of limbic system which you see them in close vicinity along with the corpus callosum. Components of limbic system. Please also note that uncus is area number 28. Now this can be a separate question, that uncus is area number 28, and this is important because it is primary olfactory area. This is primary olfactory area. The area number 28, that is uncus, is a primary olfactory area. Around the calcarine sulcus, what you will see, I hope you also remember that posterior part of calcarine sulcus was the example of axial sulcus. So that's why you will see all these important areas which are encircling it, that is a visual cortex can be seen around it. So visual cortex is arranged something like this. You will see area number 17 in the core. Then you see area number 18 which is present outside it, that is area number 18. I'm sorry, that is area number 18 here, and then even outside that is area number 19. This is area number 17, that we have is 18, and the one here is 19. Area number 17, as we all know, it is primary visual area. This is primary visual area. And 18 and 19, which is encircling 17, that is visual association area. That is visual association area, that is area number 18 and 19. So these are some important areas, these are some important must-know areas on the medial surface of the cerebral hemisphere. So we saw some important areas on the superolateral, and these are the areas on the medial surface of the cerebral hemisphere. So having talked about all these important areas on the medial and the superior lateral surface, now let us also talk about the sensory and the motor homunculus. Sensory and motor homunculus will give you an idea about that what part is represented in which area of the cerebral hemisphere. Now guys, unlike, or it is not dependent on the size of the muscle that how much area will it cover, but actually it depends upon that what kind of movement is possible at that particular joint or by that particular muscle. Like first of all, please remember that in the cerebral cortex, muscles are not represented. The gross movement is represented. My cerebral cortex is not giving off the order for the bicep muscle to contract. It is giving the order for the flexion of the elbow joint. And then the muscles which are involved in that, the synergist and the antagonist muscle, will accordingly be stimulated. So it's important to understand that cerebral cortex is not having a representation for the particular muscle but for the particular movement. And the same goes for the sensation also. Wherever we have more sensory input, like if you look at the hand and finger, we have more number of sensory fibers over there. The touch receptors are obviously more in the finger, the tip of the finger, on the face, on the lips. That is why the representation of all these areas is way bigger on the cerebral hemisphere. Similarly, if I talk about the motor area, now let me compare one randomly. If I compare the gluteus maximus muscle with levator palpebrae superioris, now imagine there is no comparison. Gluteus maximus is a huge muscle and levator palpebrae superioris is a very, very small muscle. But when it comes to the number of motor unit, the number of motor unit are more in the levator palpebrae superioris, because LPS muscle has to do a fine movement of the blinking of the eye, whereas the gluteus maximus muscle is doing, it's a gross movement, it is for the extension, right? So the more the fine movement is, like the fine movement in the finger done by the intrinsic muscle, intrinsic muscles of the hand obviously will have more representation in the motor cortex, or I should not say muscle, I mean the movement will have more representation in the cortex rather than compared to the elbow flexion or the shoulder flexion. So finer the movement, larger the this representation in the brain. The more precise the sensation, then we have again the larger representation in the cerebrum. And based on that, there is a schematic picture which is called as a homunculus. Well, homunculus means ghost only, so it looks like a ghost. You will see a body is inverted lying on the cerebral hemisphere. But that is a very good picture to give you an idea about that what part of the body is represented in which area of the cerebral hemisphere. We said area number 4 is motor cortex, fine. Area number 4 is the precentral gyrus. But in that precentral gyrus, where is upper limb? Where is lower limb? Where the fibers are trunk for coming from? Where is the head and neck fibers are coming from? So for that, we need to know about this sensory and motor homunculus. So let's talk about that part in this section.